just have to say that after your presentations, I think I'm feeling as gloomy as what the weather is outside here. But before we all get into this despair sort of framework, two things I'd like to ask, and I think it's getting more at the policy-related area. One has to do with state policy. So you indicated all these areas of health profession shortage, primary care shortage. If I were to outline another map out there around scope of practice for advanced practice nurses, those same areas in the rural areas are ones that don't have expanded scope of practice. I know that that's been a policy strategy that's been advocated by the Rural Health Association and many others. What's up with that? I mean, what's the strategy in moving that forward?
Yeah, that's boy. Let's start off with a nice, easy one. Well, I think the scope of practice issue has always been a problem in rural, and the goal should be that folks should be able to practice to the extent of their training. And yet, these are guild issues, and a lot of politics gets wrapped up in it. I think the best thing we can do is sort of bring attention to it. One of the things we've done with the National Conference of State Legislatures is on our website now you can get a sort of a state-by-state comparison of scope of practice for advanced practice nurses, dental health, mid-levels, for lack of a better term, and I can't remember the third one, but we've got 3 professions where we're looking at it. And I think you raise a good point. I mean, I think that those are state levers, and I'm not aware of a lot of research that indicates that the care differs from one to the other. So the more folks can use to compare states to states and look at those maps, the better, because I think that needs to be an honest discussion. It's not like we've got an army of advanced, of clinicians ready to go to these communities. We've got to use the folks who are there and the ones that are most likely to stay, and all we can do is shine a light on it.
So the other one that goes to federal health policy is where, as the Affordable Care Act is up for debate and up for replacement or whatever, what are the big things that you're concerned about in terms of how the changes that are on the table might affect rural communities?
I like my cat, so I'm going to let you take care of that one.
Oh, goodness. I don't even know where to start. I mean, I think that, and so we have actually done a whole body of work separate from our rural work, where we have looked at how the Affordable Care Act has impacted state and local public health around the country. And I think to that work, as you asked that question, and interestingly, it was not designed as a study to focus on rural, but I think a lot of what we saw were rural differences, that we know in our rural communities that there are provider shortages. So when you increase access to insurance, you're not necessarily increasing access to services. So a lot of people gained insurance, but they didn't necessarily gain access, so it created demand. And this, from, again, the public health focus, what this did was that this created new demand for services at health departments who, in many of the rural communities, were still serving as safety net providers. I think all of that has significant implications. What it has done is it has driven health departments, really, I think, in 2 different directions. If you are an urban health department and you've got other providers that can serve communities, it has allowed you to shift away from that direct service provision. If you are a rural health department, it has really tied you in more to that direct service provision. Thinking about what happens moving forward if that changes, I think many of our rural health departments and many of our rural clinical providers, I don't think this is unique to public health or healthcare, I think most of them are struggling. They operate on the margins, so they can't handle being twisted and turned one direction or the other. I think it just leads to more uncertainty and likely leads to more of the same outcomes that we see with hospital closures and I think with health department closures.
I guess the only thing I'd add is that taking a much longer view, I remember the big debate about Medicare Part D when it came out, and concerns folks had about would that meet the need. And I think, that program has evolved and played an important role in ensuring access, and it's now got, broad bipartisan support. Who knows what's going to come out of the process over the next couple of months. What I do think it's shined an important light on is something that really dawned on me, and that is that the way we regulate insurance nationally tends to work against rural communities. We tend to chunk up the rating areas at a very small geographic level and then get surprised when the risk is such that somebody doesn't want to offer a product there. And so maybe one of the positives that will come out of this is a broader discussion about pooling risk in a way that, and not just for the affordable care marketplaces, but for every form of insurance, small business, individual market. I think this has pointed out the challenge of sort of the variable ways that we do this. We do know that in the marketplace that Texas, for instance, their rating area was very large, so it affected positively the affordability of their premiums. Florida, they did it at the county level, and the population just wasn't big enough to really make it worth their while. And so, one of the things we're going to commission this year is some work by the Rural Policy Research Institute to really talk about the challenges of any sort of risk-based product in a rural market and how it, some of the public policy issues that come out of that.
Great, thanks. So I'd like to open it up to the audience and see if you have questions or comments from our presenters here. I'd ask that you use the mic and introduce yourselves.
I'm Melissa Simon from Northwestern University. I'm one of the roundtable members on the Roundtable for Health Equity, promotion of health equity and elimination of health disparities. Thank you very much for your talk. I have not seen any Asian data, and I know this is a constant issue regardless if you're looking rural, urban, and everywhere in between. Do we know anything about Asian in rural America?
Not in the data that I have seen. What I would say, so another resource, and I mentioned them or alluded to them in my comments, the University of South Carolina Rural Health Research Center, they have done a lot of work looking at rural minorities, so that overlap. I don't know if they have data on rural Asian populations. I think we need to do more focus looking at that overlap.
Mm-hmm.
I think they're probably the center that does it best. I've not seen it. I mean, my guess is that you would see a similar trend because, again, I think that that geography appears to have an impact independent of race and ethnicity.
And to follow up, do you know if there's a similar dynamic that's happening around urban centers? We see poverty, people with poverty and first-generation immigrants and refugees actually not going to city centers, but rather the suburbs. Do we see then the transition from people who can't make it in the suburbs going rural?
I don't know if we see that or not. I will say that we have seen over the last 10 years or so, and I think we need to dig into this data more too, but we've certainly seen poverty move out from the cities into the suburbs. That has been a major national trend.
Mm-hmm, mm-hmm.
Whether it then makes that next jump from the suburbs out to the rural areas, I'm not sure.
Okay, thank you.
Thanks.
Hi, my name is Ashley Browning. I'm from East Tennessee State University in Johnson City, also representing Appalachian Community Fund in Knoxville. I had a question, actually a couple of questions for Mr. Morris regarding EMS providership. In Tennessee, we've had quite a problem with the state eating up those EMS funds before they get a chance to make it down into the system. Knowing what we know about rural health care and these clinics that are available only until probably 5 and no hospitals available in those areas after that, that's increasing the cost to EMS, and then the funds are getting eaten up at the state. So what plans are in the pipeline in terms of, number one, helping to get that money into the hands it needs to be in, and number two, educating those EMS providers in terms of behavioral health, especially considering the mental health disparities in those rural areas?
Well, all good questions. I can't speak to the specific state issues and the allocation, but I think you have hit upon an important issue, which is the training of EMS professionals, especially as we rely on volunteers it's hard for them just to get their BLS requirements or their advanced life-saving requirements, and yet, you know, they are called in situations in which if they had a little behavioral health training would go a long way. And I just, you know, it's like how much time is realistic to put on them for requirements. I'm encouraged by one model, and to your point about it, I don't want to resume the gloominess of the day. There's a lot of good things going on in rural, and the resiliency and the creativity we didn't get to, and we probably should talk about that at some point. And in the EMS space, probably the most positive thing I've seen is the notion of community paramedicine, which I think started in New Mexico in Red River. And you know, that's just one of those situations where you see rural really saying, well, what do we have and how can we deploy it better? And so if we can get a reimbursement model that works for community paramedicine, where in their downtime they can do wellness checks, they can do home visits, they can respond to those sort of situations, maybe do more training. It's all about integration. EMS is like this separate system. It's got a dotted line back to the healthcare system, but it's also got a dotted line to transportation. It's housed in our Department of Transportation federally, not in Health and Human Services. And I think that's mirrored at the state level. So there's a lot of challenges with it, but I think if we could find ways to integrate and really expand the notion of community paramedicine, we might be able to get at the issue you're talking about.
But you hit on another issue too, and Tom talked about it in his presentation as well, that I think is really worth highlighting, which is that when dollars go from the federal agencies to the states, they don't always make it out from the states into the rural communities in an equitable way. Some of that is pressures that the states have to produce numbers. I get that, but it is something that we need to focus on. We just completed 4 regional meetings in the month of May, and I will tell you that that is a theme we heard in every one of those meetings, where states are focusing in on larger population centers so they can produce numbers, so they can justify dollars. That's the pressure they're under. I don't fault the states for it. That's the pressure they're under. But that also means, as a byproduct, that dollars aren't making it to rural communities, which are also facing very significant disparities.
Thanks.
Yeah, Dale Quinney with the Alabama Rural Health Association. First, I would like to thank the National Academies and the roundtables for coming to Alabama. We're delighted to have you. We like your showing of concern, and we have much we'd like to share with you. We're talking about federal policy. Thank God for federal policy, but all of it is not perfect. There are some things that can be improved. For one thing, the definition of rural. That's a complex issue. I know just about everyone here has a question, because when the slide of the chronic poverty counties in Alabama was shown, there were 3 urban counties. Those urban counties are Pickens, Hale, and Lowndes. Ain't no way. Not only is that not likely, there ain't no way that those are urban. What happened there and why they're considered urban? We start with the metropolitan statistical areas. The Tuscaloosa MSA is Tuscaloosa, Pickens, and Hale counties. But then there's a modification, the RUCA codes. I believe that stands for Rural Urban Commuting Areas. It looks at commuting patterns, and you get Dr. David Hart with the University of North Carolina and his research team to make those determinations and those modifications to allow some of the MSA counties to have census tracts that are considered rural. Well, according to his methodology, part of Pickens and Hale counties are considered rural, some census tracts, but all of Lowndes County is still urban. I called Dr. Hart to discuss this before he did his calculations based on the 2010 census, and asked if there was some way that he could send his preliminary determinations to people in the states for them to make comments. The Census Bureau does this. After each census is completed, but before it's released, they send their estimates by age and gender to the states, to the data centers in the states for comments to see if there's anything that looks a little quirky. I discussed the fact that Lowndes County is not in any way urban. All of it is rural. And we would like to kind of touch on this and see if we can't modify this again to make it a little better. It's not perfect, it's a good modification, but it can be improved. The other policy, and Tom knows about this because I've asked about this at National Rural Health Association conferences, and it's something that I'm sure has a solution, but it's difficult. The methodology for calculating and determining health professional shortage areas. This is a good policy, but there are blatant weaknesses, and it has to be considered as a defeatist methodology. It's producing the wrong result in many cases. The way this determination is made, every 4 years there's a survey of the county or census tracts that are designated or to be designated, looking at the full-time equivalents of primary care physician service per population. This measures the provision of minimal care, not optimal, but minimal care. There are incentives and positive things for areas that are classified as HPSAs. The physicians practicing in a health professional shortage area receive an annual bonus, which is deserved. The implication is there aren't enough people providing their service, so they're overworked. Certain grants can be applied for only if you are in a HPSA. I want to say, and correct me if I'm wrong, that rural health clinics can only be located in HPSAs. Anyway, there's the National Health Service Corps uses HPSAs and HPSA scores to determine where they can place healthcare practitioners and have part or all of their educational debt paid off. You want to be in a HPSA. That's wrong. You don't want to be in a HPSA. You want, instead of providing this level right here, that is the minimal point, where below this point you're a HPSA, you don't have enough primary care physician services, above it you're not, and you lose those incentives. We want to be able to get up to the level of optimal care. We had a county not long ago that was about to lose its HPSA status because they employed one physician too many, and they were about to go above that level of providing minimal care. Physicians threatened to leave and go elsewhere because they were going to lose that bonus payment each year. That's where the defeatist comes in. We need to have some kind of incentive built in, and it's going to take better brains than poor old Dale here has to do this, to where those areas that really get out and work at it and bring in more physician care are rewarded rather than punished. Guys, again, thank you for being here.
Thank you.
My name is Michelle Eichinger. I am a consultant with Planning for Health Solutions. I specialize in public policy as well as planning and built environment. I'm here, I wanted to go back and ask with just the challenge you had mentioned about the need for the demand for services, but yet the federal investments that are targeting programs. Looking at it from a non-healthcare perspective and trying to focus beyond the non-healthcare service model, what are some of the federal investments? Are we seeing any kind of federal investments targeting communities, not state health departments or not state agencies, but communities that address rural health and equity, evidence-based approaches, similarly to what we've seen with the CDC that have done with PITCH, the Partnerships to Improve Community Health, the current USDA grants that are out right now for distance learning and telemedicine. Are you seeing any federal investments or the potential for federal investments targeting non-healthcare services to address health issues in rural communities?
Yeah, I mean, there are some efforts in that regard. For instance, and Kara may be able to speak to this more than me, but the Accountable Communities demonstration that the Centers for Medicare and Medicaid Services Center for Innovation did, which looked at providing funds to to focus on like the social determinants, the human service aspects that affect healthcare outcomes, and they funded quite a few projects on that, with the thought being that if you could address housing, if you could address jobs, those sort of things, that you might put people in a better position to affect their health outcomes. And certainly, I think within our department, we tend to be more interventionist focused. So it's a direct investment in healthcare, and yet, I think if you get outside of where we are, USDA and their rural development programs tend to focus on this. So there are efforts under there, but they're sort of indirect. EPA has an initiative right now looking at revitalizing downtowns, and so they're looking for anchor institutions that they think can help revitalize, places where there's a lot of boarded up storefronts. So last year they're in about 5 or 6 communities, and they're trying to build around community health centers or small hospitals to do that, and that's both rural and urban. So there are efforts on that, but they're sort of fledgling, at least as far as I'm aware.
Well, and one thing I will just throw out there to chew on, and this may have its own problems, I don't know, but it seems to me that those dollars that flow through the state, regardless of what agency they're coming from, if you are in a state that has 30% of the population that's rural, 25% of the population that's rural, whatever it may be, if that same percentage of dollars could be allocated to rural communities in your state, it seems like it would at least work more towards achieving that equity.
Yes, I'm Robert McClellan. I'm from Dartmouth Hitchcock Medical Center and Geisel School of Medicine at Dartmouth in New Hampshire. And much of my career in New Hampshire, the biggest issue was actually the lack of public health services, not clinical services, but public health services. I wonder about maps that look at the disparities in basic public health services in rural areas. And then I would comment that with the creation of Department of Homeland Security, that actually did provide money to create regional public health services certainly in New Hampshire. And I wonder about that funding stream and how that may be working.
So that is probably a whole day unto itself. So that and we've done a lot of our work looking at rural public health and public health infrastructure. And the challenge in doing that work is that every state has a very unique public health infrastructure. They all developed independent of one another, and there's very little similarity actually between what health departments do in one state versus another. You have to think about inclusion and exclusion criteria. So some states may include their Medicaid agency, some may include environmental programs, and what you include or don't include affects the budget. So when you see data on health departments are funded at this amount per capita, it's fairly meaningless unless you can tease out what's included and not included. So it's very hard data to work with, and it's very hard to quantify the public health infrastructure. That's actually further challenged by the fact that some states have a centralized public health infrastructure where it's a state system which may have local units, and some it's actually locally based, and it's a county unit that operates with county dollars. So it's just really hard to do apples-to-apples comparisons. What I think we can say in all of the work that we've done, and we've done financing studies, workforce studies, a number of them, in aggregate, in general, our public health infrastructure struggles more in our rural communities. I think we've got pretty good data to demonstrate that. We've done a lot of analyses of the public health data that's collected on local health departments from the National Association of City and County Health Officials. So I'm there with you, and it's a big, big concern to me. You mentioned the DHS dollars, but there were CDC dollars, there were HRSA dollars, a lot of dollars that went into public health preparedness and hospital preparedness. That actually was a real big boon to those health departments in terms of building capacities, but those dollars are going down now. And I think that has some major implications for health departments as well in terms of their continued operations. One of the things, and we have very rightly focused nationally on rural hospital closures, I'm also very interested in rural health department closures because anecdotally we're hearing about some of these small rural health departments that are shutting their doors and struggling, and nobody's really capturing that, and nobody's thinking about what is the implication of not having boots on the ground in our communities to do disease surveillance, to track infectious disease, to do epi investigations around outbreaks, to control outbreaks, to do health education, all of the core work of public health. So I'm very concerned about that, and I think that weighs into this.
Tony, I think I'll just yield to the other microphone because
Okay.
we're running out of time. So Phyllis?
Oh, okay.
Well, we
You're
have- we
short
have
now?
time. We have time.
Okay. Good morning. I'm Phyllis Meadows from the Kresge Foundation. And first of all, thank you very much for your presentations. Very insightful. I was kind of hoping that I could hear a little bit more about your thinking and the challenges you mentioned. Both mentioned this idea of the difficulty of translating urban models to the rural. But beyond context, and I'm assuming you believe that any good program takes into account the context in which it's working, can you share some examples of where you think that translation has failed and what you believe would be, because I don't know what an urban model is versus a rural model, any characteristics that you think really shape what's an urban model or a rural model?
I think it stems mainly from the expectations of the infrastructure. So the mix of providers that you would need to carry out the model, the number of people served by the model, and then the evaluation of the model. I mentioned the diabetes education, that's one. If you think about when the ACA passed the home visitation program, it required all the states to use evidence-based models, and it really championed the nurse-family partnership, which is a wonderful model. And yet, the requirements of the nurse-family partnership were not necessarily attainable for some of the smaller communities, given the mix of folks that they would need for that. And so it's mainly in areas like that where you make an assumption that you can just take that and sort of pump it down. Well,
So
we don't.
it really is kind of looking at the context and
Yeah, I
being
think it is.
able-
It's the
okay.
context of who's actually on the ground. And I remember getting in a very heated argument with some nurses over the diabetes.
And I'm a
education.
nurse, so.
Okay, and I'm married to a nurse, so I'm going to get in trouble at home. So the diabetes thing. I mean, even an AD nurse gets a really strong training in diabetes education, self-management. And so the thought that we would make that this sort of multidisciplinary team, it's great in a perfect situation, but all it did was mean that those folks were still providing those services and not being able to bill for it, all because of a construct that was never really envisioned when it was passed. Now that's gotten better since then. They've diversified the teams, and there's other accreditation models. So I think it's more about thinking about it on the front end. What Mike was saying earlier, I think, is another good example, and that is if you test a model out in a rural area, it's a lot easier to ramp it up than as you bring an urban model down, you have to discard pieces. And as you discard those pieces, do you decrease the effectiveness of what made it an evidence-based model? And so if we could do more of testing out with a bare minimum of folks, then you can add people in and see. It's all how you look at it in that regard.
Very helpful.
And I would add, the context of history and culture. The work that we're doing right now on strengths and assets, we haven't talked a lot about strengths and assets, but rural communities are close-knit. People know each other. They come to each other's aid. They're resilient. There are a lot of really positive factors about being in a rural community that can be leveraged. And I think we can test models on a smaller scale, lower dollars, less noise, because there are less other things going on that'll could potentially influence the outcomes. And because we're starting at a higher level of disparity, there's more room for upward momentum, upward growth. So I think there are a lot of reasons that actually we may be thinking about testing models wrong. The other thing that we have certainly seen in our work is that there are really amazing things going on in rural communities all over the country, because one of the things we hear is that a lack of resource actually leads to innovation. And we often don't think about that, but when you don't have a lot of dollars coming in, you got to be creative in terms of thinking about how you get things done. If we can capture that and figure out what is it that can be distilled, exported to other rural communities, but also potentially scaled up to influence urban outcomes, I think there's a lot of opportunity there. The problem that we have is that every community works in its own bubble, and we don't know where to shine the light to find those innovations.
Yeah.
So I think there's a lot of opportunity.
Thank you very much.
The other point I would add to that is you don't need a lot of money to make a difference in a rural community. Our grants that Mike's group is evaluating, $200,000 a year for 3 years, with the idea being that we get the project going, and then we step away and you keep it going, and we stay in the 90 to 100% retention rate in terms of them keeping the project going. And so, you know, it's sort of interesting when I watch some of my federal partners, you know, they think in terms of millions, and I think in terms of, you know, thousands.
Thank you so much.
Ned,
Sorry, I had the
welcome
time
back.
wrong, Tony.
You did,
So,
you did.
Ned Kalonge, Colorado Trust. Actually, you guys are way more optimistic than the newsletter from the National Rural Health Association. So, I wonder, within the limits of prudence, you can give us advice around how to get the attention of federal policymakers as they think about things that follow an agenda that has the potential for great harm to rural America, especially in the healthcare sector. I think we're all concerned about it, and I understand what you can and can't say, but I think we're all trying to think about how to help you, Tom, how to do what we can do that won't be harmful and that will actually keep rural America in the hearts and minds of policymakers within the Beltway. Thanks.
So I can probably say more in that regard than Tom. And I think about this issue a lot. I think we, and I kind of speak on behalf of both the rural health community and the public health community, I kind of cross between both. I think we need to do a better job of communicating to the residents that we serve the benefits that we bring. I think that when the issues are framed properly, they support the activities that are being provided. They may not, if you ask them about, you know, do you want government services, they may say no because they have a negative perception of government. But if you frame it independent of the government piece, they want those services. So we need to think about how we communicate that. So I'll tell you very quickly, we just are completing a body of work at NORC, and we are looking at how different groups of Americans think about health. And the implication of this is how do we communicate health to different groups of Americans? And when we analyze that data by geography, you know, no surprise. The big factor is if you are focusing on public-private partnership, if you're in the rural community, talk about the private side of it. So there's a lot in the messaging that I think we just need to be much more mindful of. And I think if our residents support us, they will communicate to those policymakers, and they need to be empowered to do so.
And Ned, I thank you for that. I think I would build on that. I don't mean this to sound overly sort of pie in the sky, but rural health has traditionally been a bipartisan issue. I've been in the government about 21 years now, and you know, we've had great support from Republicans and from Democrats, and yet there's no denying the context in which we're now operating and how contentious it can get. And yet, if it can get outside of the Washington, D.C. area when folks are back home, I think they largely have a common ground about caring about the issue, very different thoughts about how to get at it. And if we can keep the discussion on the issue and the challenges, I think that's the best thing we can do. Mike's data, and I was talking at breakfast with some folks about this, and I'm sort of a broken record on it. The data on avoidable or excess deaths in rural communities and how much higher it is in rural than urban is so compelling to me, along with life expectancy, because that is not a partisan issue. That's a real, you know, those are real metrics. And I think that if you start with those data points, it allows you to talk about all the challenges we've discussed today. Lack of workforce, economic challenges, despair, opportunity for creativity, the chance to move the dial. So perhaps if we can get it out of the political fray and talk more about what's going to work for rural communities, we have an opportunity to do that. And the other thing is, I think, you know, regardless of the budget issues, there are a lot of resources across HHS. There are states that are invested. Thank God the foundations and the work they do. How do we help rural communities connect to what's there? And they really struggle with that. And so it's not just a federal thing. It's a federal, state, and a philanthropic thing. Is we can do a better job, I think, of connecting people to resources and helping them understand what's going on, and then come up with the solutions for their own communities. Again, not to sound overly
Well,
simplistic.
and the only thing I would add on top of that is that, when we hear the word rural, we automatically think small, but we need to be thinking in aggregate. This is almost 20% of our U.S. population that faces some of the greatest disparities we have in our country. If we frame it that way, if we are concerned about health equity and 20% of our people are facing dramatic disparities, I think there's opportunity for a clarion call on how do we address this.
Good morning. Thanks so much for two outstanding talks. My name is Bronson Tucker Edmonds. I'm an obstetrician gynecologist at Indiana University. I serve as the anniversary fellow for the National Academy of Medicine through the American Board of Obstetricians and Gynecologists. So I'm very selfishly here to ask you a question about maternal mortality. And I was interested in the stats that you were putting up regarding the mortality indices, and just wondering if you were aware of any sort of deeper dives or similar types of analyses that were constructed. I don't know if folks in the room are, but you all are probably aware that we're really the only industrialized nation right now with a rising maternal mortality rate, and so I'm just trying to figure out whether there are any insights as to whether some of this geographic piece has a contribution to that dynamic. Just as a slightly separate question, because I know I'm being greedy for time here, the other piece that goes with that, because I was just reviewing a journal article on this issue about obstetric unit closures, which disproportionately impacts, obviously, urban and also micropolitan settings. And I guess one of the pieces that came out in there, if you could just touch on it as you share your thoughts and answer my first question, is this challenge around sort of quality and volume, as you talk about the evidence base and some of the challenges and traps that creates for the rural locale. How do we kind of wrestle with that tension? What do we do with these pushes toward regionalization, and that they not be at the, is no care versus suboptimal care, like how do we deal with that? So if you could comment on any or all of the above, I'd appreciate it.
So I would need to go back and dig into our data a little bit more. I don't know if I have it off the top of my head, but with the mortality study that we did analyze by age group. So we have infant and young child mortality rates. So I'm sure there probably are differences. We can certainly see that.
But not maternal.
So with that data in particular, we looked at 10 leading causes of death, so I don't know that we have maternal mortality within that data set. It may be within our larger chart book, but I need to go back and look at that as well.
And, we have that data in our maternal and child health branch, and we had a meeting recently, and somebody asked the same question. And I thought to myself, I needed to ask Dr. Michael Liu, who's the head of our maternal and child health branch, about that, because we could cut that rural and urban. And I would suspect, we'd see some striking findings in terms of that. And it would follow what you've already talked about, the loss of delivery services in rural communities. Our University of Minnesota has released a couple of really interesting studies that talk about that hospitals are dropping these services. And the dynamic you've mentioned between how many deliveries do you need to do to meet a quality threshold is an important one. And yet I'm reminded, one of my predecessors in this job was an old pediatrician named Wayne Myers, and he often said, well, a pretty good trained somebody is better than a perfectly trained nobody. And, I was like, okay. But I do think there's something to do. The National Advisory Committee that Octavia sits on, about 10 years ago, they did a study that looked at, rather than just looking at who's doing OB and who isn't, let's look at where women of childbearing age are, and they proposed doing centers of excellence based on where there was enough population to meet the quality volume threshold. And that issue didn't really get any traction, but I do think that idea is still pretty relevant in the sense that we probably could have more access to delivery services in rural communities if we aligned it better with where the need was, instead of just the capacity to do it. And then the other one is, I think there's more we can do around fetal monitoring and telemedicine. I'm struck by a program in the Sierra Nevadas where UC Davis put fetal monitoring units into small hospitals up in the mountains. And what that allowed them to do was keep women in the community longer, ship them when they needed to, and it also allowed them to attract physicians because they felt like they had the support to do OB care in their community. So I think this is a really interesting issue and one that needs more analysis and then finding out if we could test out some models to do it. There's also some data from Minnesota about where the Medicaid births are happening in rural, urban, and so we're hoping to fund more in this area in the coming year.
And access to prenatal care, which also brings back in some of that public health lack of infrastructure as well.
Thank you all.
So we have 15 minutes, and we'll limit the questions to those that are at the mic. I do have one question that, and just ask us to be concise with our questions and also our responses. I do have one question that came over through the web that I think is appropriate as we're looking at data. And the question is, how has the opioid epidemic affected rural minority populations? Do you have any data on that?
So I think we need to dig into that data a little bit more too. So we know that the opioid epidemic has affected rural populations in general disproportionately. We also know that the opioid epidemic has disproportionately affected working class white populations. However, there is some new reporting. There was actually an article in the Washington Post this weekend talking about how the opioid epidemic is now crossing over into the minority population, and that we're seeing minority population rates rise dramatically, but that data was not rural minority population. So I think we need to bring all of that together and see what's happening. I suspect that we will see, just like with every other issue, that geography has its own independent impact, so that it probably is affecting rural minority populations greater at this point than non-rural, but that's just a hypothesis.
Great, thanks.
Thank you. George Isham, co-chair of the Roundtable on Population Health Improvement, senior advisor at Health Partners in Minneapolis. Thank you very much for your presentation and drawing attention to the geography. I particularly struck with your maps and so forth, particularly the map that started with poverty as a root cause. My word, root cause, you didn't use that cause, but it seems like that's one of the root causes. And then the other that you mentioned was history and culture. You just mentioned that sort of as you passed by. I had the opportunity to have dinner with Jennifer DeLaha, health officer in Arkansas, last month when I was in Washington for the Health Literacy Roundtable. And she's responsible for health literacy in Arkansas. And we were talking about geography, and she showed me the maps, sent me the maps of Arkansas with respect to mortality and health literacy and the pattern of that in that state. And then sent me a map of the 1860 census of slavery, which looked to be roughly the same pattern. It occurs to me that in our conversations in the Population Health Roundtable, we've had some comments about structural racism and structural factors in society. And it raises for me the question, maybe you can help me connect some dots here, about the relationship between history and culture, the persistence of disadvantage in certain geographies, and the relationship to race. I'd really appreciate if you could help me connect some of those dots. It seems that if we can do that, we can begin to think about policy solutions that get at root causes, instead of some of the more derivative sort of issues around that.
So, I think another much larger discussion, but I think you are already connecting the dots. I think you're right. And I think for each of those regions where you see persistent poverty, there is a story to tell. So I think in the South, in the Delta, slavery is part of that story, part of that history. Indian reservations, there is a clear history. Along the border, there is a clear history, and we just conducted one of our meetings along the border, another one in the Delta, and we heard a lot about those histories. The other one that is interesting that I think may be less commonly known, but I'm actually reading a book about this now, is that Central Appalachian region, Eastern Kentucky, which has a really fascinating history of its own, which dates back to the Civil War, where Kentucky was a neutral state. And as a result, even though there was a lot of fighting, and a lot of fighting within families even, a lot of destruction, because they were a neutral state, they were not eligible for any Reconstruction dollars. So that part of the country got left behind. So again, you see history weighing into this. And that continues, I think, to play out to this day. So yeah, I think you're right. I think you cannot separate this from culture and history, and I think that's something we need to delve into much more deeply.
What's the agenda for study to really understand those factors?
It's a great question. I think you know, I am a big fan of storytelling and getting the anecdotes and stories from the people in these regions to bring to light what has occurred in the past, but what continues to be perceived through that today. And you know, I will tell you, when we held our meeting in the Delta region, people did not want to talk about race and ethnicity. It was a mixed group of individuals, but people talked a lot about land ownership and power. So thinking about how we approach those issues and how we tell those stories, I think that's a piece of it.
Thanks.
Hi, good morning. My name is Kara James. I'm with the Centers for Medicare and Medicaid Services and also with the Roundtable on the Elimination of Health Disparities and the Promotion of Health Equity. And I'm glad the last couple of questions have come up because I wanted to kind of bring the conversation a little bit back to health equity. And Michael, you were sort of tasked with kind of giving us a lay of sort of what we know about disparities and that sort of intersection of race, ethnicity, and morality. And we didn't actually hear a lot about that. And I mean, sort of what was presented was kind of where we have large pockets of the population, but the point that you made about American Indians, where there are large pockets in, you know, the Dakotas, but they still represent only about, you know, 7% in most in those areas. So the data is really what we're seeing for non-Hispanic whites. So I kind of want to put back the question to you of what do we know about the disparities, sort of racial and ethnic disparities within rural communities around health access and the intersection of all of the social determinants.
Yeah, and again, I would refer you back to the folks at the University of South Carolina because they do that work better than we do. They really specialize in looking at that intersection. But you know, I mentioned this kind of as my preface at the very beginning. We know that for every racial and ethnic group, if you analyze data by geography, you will see a disparity between rural and non-rural. So we know that there is this interplay. It is a dual disparity. Yes?
I guess it's less the urban-rural and what's happening if you just look at within rural. Because it's a different story. And so I guess that's the story I was kind of hoping you could kind of pull out as we're here talking about how do we get rural health equity. It's also a question of where there are disparities within rural communities by race, ethnicity, and other.
Got it. I don't know that the data are, I think the data are there. I don't know that they have been analyzed to necessarily do that pinpointing. Now we know where rural minorities live, so that helps us to do some of that pinpointing, but I think we probably need a bit of a deeper dive in terms of the magnitude of those disparities across rural by race and ethnicity. I think you will see, my hypothesis would be that you will see those parallel lines again, that when we look at data by race and ethnicity nationally, we see that certain racial and ethnic groups do better or worse. And I think you'll see that absolutely shown again when you separate out the rural racial and ethnic data. It's going to just be a higher line because it's a dual disparity.
So my name's Dennis Johnson. I'm with Children's Health Fund, and just briefly, because I know we're short on time, I noticed that they were excellent presentations from both of you, but I noticed that in some of the slides where you broadened the lens a little bit to look at the other factors and other players that were involved in helping rural communities to achieve health equity. Well, we support a network of mobile programs, and a half dozen of which are in rural communities. And I've been at this work for a quarter century, and what I've heard continuously is that the dearth of transportation resources and the lack of public health resources in these communities is a huge factor. But, and I don't know if when you, Tom, when you referred to infrastructure, and you more recently just said something about connecting communities, and of course, Michael, when you had your slide, and you'll have to forgive me because my vision isn't what it used to be, but that was a very busy slide, and I tried to to look at it to see if transportation was included in all of the things that were listed, and I didn't see it. So I was wondering, could you talk a little bit about some of the challenges, both federally and in local communities, because now we're seeing with some of the contemplation of how the fundamental integrity of Medicaid is going to be, in my view, compromised, and services that are embedded within those very critical programs, especially for kids, of non-emergency medical transportation and those resources, how that figures into your assessment of what we need to look at in rural communities in terms of health equity.
Well, I will quickly tell you that every rural meeting we have done, the two issues that come out at the top in terms of infrastructure capacities are transportation and broadband. So we are aware of it. It is a challenge in our rural communities. I think it is on the asset map. It is an asset when you have it. Mm-hmm. It's a challenge when you don't. So transportation is probably the number one issue we hear about. Broadband is another one that, particularly as we think about telemedicine, I think people take for granted that broadband is everywhere now. It's not.
Yeah, I couldn't agree more. I glossed over a lot. Transportation, critically important, and yet the only thing I'd add is that sometimes we make it harder than it needs to be. We may fund a Head Start van, but it can't take anybody else because of liability issues. We have school buses that can't transport others. You have senior services, and they can only take seniors. I mean, I think there are probably ways we can get more creative if we would just untie ourselves. But even if all that happened, I think transportation would still be an issue for rural communities, and it does have implications for access to care, continuity, all those things. So thank you for raising it.
So last question and response between now and break. So make
Well,
it good.
maybe I'll make this very brief. Mary Pittman, I'm president of the Public Health Institute and a member of the Roundtable on Population Health Improvement. And I guess this is a follow-up to some of the last questions that you've received. As I was sitting listening to your really interesting presentations, and it made me think about a number of things, I felt like we fell into the trap of sliding into healthcare. And in the last few questions, we've really started to lift up the health and all policies and the social determinants of health. I'm just wondering how we might be able to take the great data that you have and remember to put it in that broader context of population health, because I think it reinforces some of the biases about where we invest our resources. And you started out by saying that poverty and some of the social determinants were really the major driver. And I wonder if you have some advice for us and others to avoid that trap.
Yeah, well, I have a lot of thoughts on that topic. I have really spent my career at the nexus of rural health and public health. And what has been really interesting to me, I often tell a story because to me it's kind of, this is overstated, but it's kind of the outcome of this is when I go to public health meetings, I'm always recognized as the rural guy, and when I go to rural meetings, I'm always recognized as the public health guy, and it makes me wonder whether I'm the only guy. There are others, so I don't want to take away from any of my other colleagues who work in rural public health, but there are not many people who really look at that. We have thought in this country of rural health as an access to care issue almost exclusively. And access to care is a significant issue and continues to be in our rural communities, and we need to maintain that focus. But there are so many other challenges that we are not nearly as focused on, and you're right, we fall into that trap. I love that you called it a trap because it is. I would call on our other federal agencies to also have that dedicated focus on rural health. It's great that CDC is now looking at rural health. That's the kind of thing that needs to happen. So as our National Public Health Agency, I want CDC to be focusing on these issues, just as HRSA has focused on these issues around the access issues. They are, in my mind, the access agency. That's their domain. They do a great job of it. It would be nice for other agencies to have that similar dedicated focus within their own domains, and then to bring them all together. I would also call out not in a bad way, but call out the national public health organizations and associations, probably other sectors as well. I know public health. They have not talked rural either. Nor has the National Rural Health Association done a great job of talking public health. They've tried over the years. I used to chair their public health constituency group. They've tried over the years, but their membership is largely hospitals and clinics, so they talk about access. The public health organizations tend to have more urban membership, so they don't talk about rural. We need to bring this all together and talk about, I think, rural population health, and I think that is the path forward.
Thank you.
Just five seconds, I would just say, as challenging as some of the health service issues are, we also, the committee we staff has Health and Human Services. As I've learned about Administration for Children and Families, Administration for Community Living, the human service rural infrastructure is even more stretched than the health. And so, yeah, we tend to look at it through a health perspective, and we're missing that whole part about jobs and employment and economic sustainability and family. So I take your point.
Thank you.
So please join me again in thanking Tom and Michael for a great overview. And I think a great beginning to the conversations that we'll have about health and healthcare, about not only rural disparities, but the intersection around health equity here as well. You all have deserved and earned a very well-deserved break, so you have 15 minutes. So we'll see you back here at 10:30.